This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. We do a Q&A with Dr. Brian Schmutzler every episode, and here in episode 3, our main topic is going to be the 3 best and 3 worst things to do before surgery. I'm sure we've all done bad things before surgery. The question is it terrible, and will you cancel the surgery?
There are some things.
Okay.
We'll get into it.
So, obviously, every episode here, Brian, we try to answer the viewers' questions and the listeners' questions, and we'll have 5 rapid-fire Q&A questions at the end of this podcast. But straight away, let's get into the main topic, the 3 best and 3 worst things you can do before surgery. Before you answer that question, what is the worst thing you've seen somebody do, or the worst thing you've heard of that somebody's trying to do before surgery?
Yeah, I mean, so the one thing that will inevitably get your case canceled is if you're eating. So I've seen people actually walking into the waiting room at the hospital with a McDonald's hamburger in their hand. So that's probably the worst. And I guess we'll start with the 3 worst things, because that's a good lead-in.
Why can't... Okay, what is the eating?
Yeah.
Just go over this for the person who maybe has never had surgery before,
Sure.
right?
Sure.
They're out there. Why can you not eat before surgery or drink?
Yeah. Okay. So let's walk through the guidelines, then I'll give you a little bit of background on it. The guidelines are that you should not have any food at all for at least 8 hours before surgery. Some would say 6, but those recommendations come from a study done a long time ago on people who ate 2 eggs, so over easy eggs, and 1 piece of toast. That was the study, and they looked how long there was food in the patient's stomach.
So this was obviously done as research.
Correct, yeah.
So did people they were ready for them to choke basically during the surgery, or what?
No. So it wasn't people having surgery.
Yeah.
So they just brought in healthy volunteers.
Yep.
Fed them the 2 eggs and the 1 piece of toast.
Yep.
And then measured what was in their stomach over and over again at different time intervals. And I can't remember all the time intervals. I think it was an hour, 2 hours, 3 hours, 4 hours, 8 hours, 12 hours. They just kept going back in. The old studies, I think they actually did a scope where they looked in with a scope. The newer ones, they've done them since. They just do gastric, an ultrasound. And so you can see what's in the stomach with gastric ultrasound. That's actually a great topic. We should talk about gastric ultrasound at some point. I just thought of that. But so that food sits in your stomach. And so the guidelines are 8 hours. Some would say 6 for any solid food. 4 hours for breast milk.
Okay.
Apparently it processes more quickly than other food. And then 2 hours for clear liquids. Okay. So if you want to have some water, and this is, again, I'm not your physician, but if you want to have some water the morning of surgery and your surgery is scheduled at 10 a.m., finish drinking that water around 6 a.m.
So theoretically, you could get up and eat super early if your case was at 12 or 1.
Yeah, you could. Yeah. The problem comes in, the days don't always go perfectly, and you may show up to surgery 2 or 3 hours early, and they may say, we're ready to go right now. And then you'll have to say, well, I had something to eat 4 hours ago. And then they're going to say, well, never mind, we're going to have to wait. So, all right, so those are the guidelines, right? Okay. So why? The reason is when you go under anesthesia, you lose the ability to protect your airway. And like we've talked about in multiple answers to questions and in the podcast in the past, you also get more nauseous, right? The anesthetics make you nauseous for the most part. So you've got the combination of food in your stomach, being nauseous, and inability to protect your airway. So you're likely to throw up, and that then goes not out, but back in and into your lungs.
So it's kind of I don't know if I want to equate it to this. Don't follow this. I'm not your doctor. I'm not your, whatever. But we see this with people who pass out.
Correct.
If they've had too much alcohol, right? They pass out, they're in the wrong position.
And they aspirate. Yeah, it's called aspiration. So that those food particles, or even if it's just bile from your stomach, can go into your lungs. The lungs don't like anything in there besides air. So if that goes into your lungs, it causes what's called the pneumonitis. So there's inflammation, and the lungs kind of try to wall that off, and in the meantime they can't do air exchange, which is what they're there for, right? You can't get oxygen in and carbon dioxide out. So aspiration is a huge issue, probably one of the most important things in anesthesia. And so that is, some studies would say, a 50% mortality rate if you aspirate. Really? Right, yeah.
50%?
Yep. Some studies would say a 50% mortality rate.
What is your experience with that?
So I've had one major aspiration in my entire career. I think there's often people who aspirate a little bit. And if you just aspirate a little bit of, let's say, stomach acid, you had appropriately not eaten or had anything to drink, and you just get a little stomach acid up and then a little bit comes back in. Usually that's not a huge issue. Major aspiration of food particles is the big issue. And so I did have one case where I had a patient who they claimed they didn't eat, even when I saw them.
So they lie to you, or they lie on their sheet.
I'm not making any I'm not making any statement of whether they lied to me or not, because I spoke to that patient several days later, and that patient still said they did not have anything to eat. But I was doing an orthopedic case with LMA in because the patient couldn't have a spinal. And the LMA doesn't completely protect the airway. That sits in the back of the throat, doesn't go all the way in the windpipe. And over the course of the procedure, there was some stuff coming up into the back of the throat. And then eventually there were just large particles of what looked like eggs and biscuits and gravy.
You can actually tell what they have?
Yeah. Yep, you can if the food particles come up, for sure. So that patient did aspirate, had a very significant aspiration. In fact, I called the intensivist, the pulmonologist, into the room to do a bronchoscopy and go down, and that intensivist was picking out pieces.
So that's what you have to do?
Yeah, I mean, if you have a major aspiration of food particles, the only way really to prevent a major disaster is to have a pulmonologist do a bronchoscopy.
Holy cow.
Yeah. So that's the worst aspiration I've ever had. I've had multiple patients who have had, small level aspirations. You can tell they've got a little bit of bile coming up in the back of their throat and it goes back in. But again, usually that's not clinically significant, or at least not a major issue.
Biscuits and gravy.
And eggs, yeah. Yeah.
That sounds like a heavy breakfast.
And we're maintaining HIPAA. I'm not telling anything telling anything about patients' names and nothing specific about the patient. So we just want to clarify that as well.
So let's, now that we've gone into that, the 3 best things you can do before surgery.
3 best things. All right. So number 1, be honest with your anesthesiologist, anesthesia provider, surgeon, right? So tell them about your medical history. Tell them about any issues you've had in the past. Tell them about if you've had something to eat or drink. It doesn't mean necessarily your surgery is getting canceled. It might just need to get delayed a little bit. So that's probably number 1. Number 2 is hydrate. So I know you can't drink up to 2 hours before, but the day before or even the week before, really hydrate, because hydration is going to do a few things. Number 1, it's going to make you feel better after surgery. Dehydration is probably one of the main reasons that you get nauseous after surgery. So hydrate. Okay. So it's going to prevent the nausea, number 1. Number 2, it's going to be easier to get your IV. Okay. So we got to put an IV in basically every patient that we do surgery on. If you're dehydrated, even from that 8 or 12 hours where you haven't had anything to eat or drink, it's really hard to get an IV in. So if you've spent the last day or even week hydrating, much easier to get an IV in. And so that's a huge thing that the patients really worry and complain about is having to have multiple sticks for the IV. And then post-surgery, it's better for you, right? So if you get dehydrated, there's a lot of bad things that can happen. Your kidneys can shut down. You can have heart problems. You can have potentially lung problems. So if you're hydrating beforehand, even if it's a minor procedure, you're less likely to have those complications afterwards. So hydration is aside from being honest with your anesthesia provider or your surgeon, hydration is probably number 2. Did you have something you were going to ask about that? Okay,
no,
right.
That's it's actually good to keep in mind, because I'm looking back at my surgeries, and I'm thinking, okay, well, maybe why did I have a headache, or what, because I didn't drink enough water beforehand. So you just don't think about those things, right? You think, I'm going to be in and out, and it's not going to be a problem, and it is what it is. You just don't think as a patient.
Right.
you don't think, hey, I can do things prior to surgery that are going to be more beneficial to me post-surgery.
Yeah.
And what was the third thing?
So the third thing is optimize your health, right? And this is just in general, you want to optimize your health. But if you can optimize your health, you're going to have a surgery in 6 or 8 weeks. Do the best you can. So number one in optimizing your health, quit smoking. Okay. Now and we can talk about this in a future podcast. There are some complications that can occur if you stop smoking within like a week or two of when you have surgery. We'll deal with them. They're not critical complications most often, but quitting smoking several weeks ahead of time, number one thing that you can do in terms of optimizing your health. Losing weight, making sure you're on the right medications, optimizing your blood pressure, optimizing, your fitness as much as possible. You got to think surgery is a very stressful experience. Even a minor surgery is a very stressful experience on your body. So you want to treat surgery as if you're going to go, run a 5K or run a marathon, depending on what surgery you're having. So you want to optimize as much as you can. Modifiable risk factors, we talked about this before, optimize those as much as you can before surgery.
And I'm guessing as we go into the list of the 3 worst things that we've already discussed.
Number one.
The number one worst thing that you could do is eat before surgery.
Yep.
All right. And number 2.
Number 2 would be smoking.
Okay.
Being a smoker and smoking the day of surgery are very, very high risk things to do. Again, even for the most minor procedure.
Okay. And the third thing.
So the third thing would be not preparing yourself for how things are going to be after surgery. So what we find is that patients who are prepared for the pain, for the nausea, for that sort of stuff, mentally prepared, do better. Right. Okay. So if somebody wakes up and they think I'm not going to have any pain after surgery, classic procedure is a gallbladder procedure. Right. So we do a ton of gallbladder procedures. A lot of patients have their gallbladder taken out. There's certain days I've done 8 or 10 of those. Okay. People think, it's a little procedure, not that big of a deal. It's one of the most painful procedures afterwards that is out there. I mean, those patients wake up and are really, really uncomfortable. Being prepared for that is going to make your transition post-surgical much, much easier.
Okay.
So, having that conversation with your surgeon or anesthesiologist or whomever, hey, what should I expect after surgery? And if you're having that conversation with your surgeon a few weeks ahead of time, it gives you time to prepare. This is what's going to happen after surgery. You're going to have an incision here. You're going to have pain here. You're going to have pain there. You're going to be nauseous. You're going to, all these things. It's having the mindset of what may happen after surgery helps a ton.
The most painful, I might be going off topic here, but you were just talking about anesthesia, but more in general, the type of procedure that you're having and underestimating it. The most painful procedure I've ever had done is a sports hernia.
Yeah.
Oh, man. That, not in terms of the procedure itself, but post-procedure. Like, it is in the, it's right.
Groin, yeah.
Yeah. I mean, but it's every movement is pretty much based on moving your torso like that.
Yeah.
And it was so painful. I wish somebody would have told me, hey, just prepare yourself for post-surgery because it is not going to be a pleasant experience.
And that's a great question to ask your surgeon. You walk in the office, you say, hey, I need a sports hernia done. Tell me about your patient's experience after surgery. What's the pain like? What's the nausea like? What's the recovery time? How long until I can, lift weights or run, on a treadmill or whatever. I mean, just having that conversation, I think probably helps. I've never had a sports hernia, but I have heard that before, that they're quite intense.
This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. Of course, we do a Q&A rapid fire at the end of every podcast. And we've reached that now. We've talked about the 3 best things to do before surgery and the 3 worst things to do before surgery. Do not eat anything. Biscuits, gravy, whatever. They don't want to see it.
Nope. Did we mention don't eat before surgery?
Don't eat before surgery. Right. Yeah, we've mentioned that. Right. Now it's time to get to your rapid-fire questions. Of course, if you follow him on social media, he's on Facebook, Instagram, TikTok, YouTube. He's going to be taking over the world soon. So maybe running for public office. I don't know.
My wife told me that she would no longer be my wife if I ran for public office, so I will not be running. I'm officially announcing I will never run for public office.
Didn't a certain politician say the same thing like 10 years ago? Or?
I mean it. So.
Okay. All right. Well, we'll believe you. But you will answer these rapid-fire questions.
I will.
This is, again, from you, the viewer, the listener out there. Here's the first question today. Is twilight sedation ever used in a hospital setting? This person said, I only ever heard of it for plastic surgery.
Yeah, so it depends what you mean by twilight sedation. I'm just going to assume you mean basically a MAC, and we'll do an episode on all the different types of anesthesia. So essentially, what a MAC is we don't put the patients so asleep that they can't breathe, and we have to put an airway in. That's essentially how I describe it to patients. So you're asleep, you don't know what's going on, you're not feeling really anything, and you're not going to remember anything, but you don't have a tube in to breathe for you. Okay, so that's what we call monitored anesthesia care, or a MAC. We use twilight sedation for all kinds of stuff. I mean, if you look at, we'll do several procedures where we do spinal blocks and use that quote unquote twilight sedation with it. We do colonoscopies with twilight sedation. We do our cataracts with sedation. I wouldn't probably call that quite the same. That's more sort of a moderate sedation where we don't give propofol. We give a medicine that just makes people not care and not remember. We'll use that type of sedation for basically anybody that has a block where really we just need them asleep enough that they're not noticing what's going on, and not so much that we actually need it for the anesthetic. A lot of times we'll do AV fistulas for people who need dialysis. We'll do that with a block and twilight sedation. So we use that a lot. And honestly, with the advent of regional anesthesia, it's a lot more common to use a MAC combined with a regional anesthetic.
I've been following along in your social media channels, and I know this is a question you get a lot, and patients have this question a lot. Why can't patients remember waking up in the surgery room instead of recovery? So, like, if you wake up in there, why can't you remember?
Yeah, it sort of depends on the anesthetic. We don't often wake people completely up in the operating room. That's for a number of reasons. One, most of our anesthetics take a while to wear off. So while you may be breathing on your own, you may not have an endotracheal tube in or an LMA in, you're not fully awake in the operating room. And we're not pushing to get you awake, right? As long as you're safe, your vital signs are okay, and you're breathing on your own, I don't necessarily care if you're awake and cognizant. I care more that you're safe. Number two, depending on the anesthetic, we may actually take you from the operating room to the recovery room still essentially asleep. Now, we as anesthesia providers, we don't leave your side until you're awake and maintaining your airway and doing well enough vital sign wise that we don't need to monitor you as closely as an anesthesia provider. But I don't mind if you wake up in the recovery room as opposed to the operating room. Those are probably the two reasons that people think that they wake up in the recovery room. The other thing is, even if you are waking up and totally awake in the operating room, there's still those anesthetics hanging around. So you just don't remember waking up in the operating room. Usually people remember waking up in recovery.
The next question has to do with artery lines versus vein IVs. So if you can explain what each is. This question says, when are artery lines used versus vein IVs, and why do they hurt so much?
So that's interesting. I wonder if this person is in medicine or healthcare. So we use arterial lines and IVs or venous lines for completely different reasons. We inject things into venous lines. We take things out of arterial lines, or we measure blood pressure via arterial lines. So totally different things. Everybody gets an IV, well, I mean, unless they're just having oral sedation, but almost everybody gets an intravenous line, an IV line. That's where we give our medications, we give our fluids, all that kind of stuff. So that's a very, very common thing. Almost every patient gets that. An arterial line is for patients who are either having higher risk procedures or are sicker patients. So there's a few reasons we'll put an arterial line in. Probably the main reason we put one in is to measure blood pressure in real time. So I can put an arterial line in and I can measure your blood pressure as it happens instead of doing a blood pressure cuff, which only takes every 3 minutes, 5 minutes, 10 minutes. Then we can also pull off blood from there and that'll give us the ability to do labs in real time as well. Why do they hurt so much more? Well, typically they're larger and typically they're deeper. And for some reason, it seems like the arteries are a little bit more sensitive to being poked than the veins. So it's not pleasant to get an IV, but once they take that IV out, you get a little bruise and you don't really notice much. The arterial pokes, whether it's, a radial arterial line or a femoral arterial line, people tend to have just more issues with that. There's a little bit more inflammation involved and just more pain.
The last question is actually from me because I kind of thought about it on the fly here. And it has to do with the conversation and communication between physicians. Mm-hmm. How much of that goes on prior to surgery between you and the person who's doing the surgery? And what do you talk about?
Yeah.
And I guess, does that have anything to do with, I know that everybody comes in and asks the same question.
Sure.
How old are you? What are you getting done today? Is this the, but how much communication goes on behind the scenes between you and the actual, another proceduralist?
Yeah. So we talk quite a bit. I spend most of my time at one place. So for me, I know exactly what those physicians want, right? I've worked with most of those guys for 10 plus years. So I know what they want. I know when a patient comes in that they want a spinal and a nerve block and a sedation, right? I know that about what they want. But we do communicate, hey, this is a little out of the ordinary. Hey, I've got this patient who I need to do a special procedure on. What do you think about that? And so there's quite a bit of communication. Almost every one of them, I have their cell phone number. We text. We'll talk during, if I'm in a procedure and the next procedure is the one where the patient has something funny going on or the procedure is going to be a little bit different than normal. We have that conversation. So there's a lot of open communication.
Is there ever a disagreement?
Yeah. Oh, yeah. There's definitely disagreements. Sometimes surgeons will say, I want you to do this type of anesthetic. And I'll say, no, because either it's not safe or it's not going to work. Usually, again, I've been in the same city and practicing with the same surgeons for multiple years. Usually they'll say, okay, well, I trust you.
They just trust your...
Right. We do, probably the most contentious disagreements we have is whether this patient is safe to do or not.
Okay.
And so, there's some give and take there. I would say in general that I'm pretty liberal when it comes to what cases I'll do. I'm pretty comfortable taking care of sicker patients. But there are some times where it's absolutely inappropriate to do a procedure. And if it comes down to the safety of the patient, I'm going to tell the surgeon, we're not doing this procedure today.
Let's put a bow on the 3 best and the 3 worst that you've ever done. How many cases do you think, just give me a ballpark.
Yeah.
Do you think you have had to cancel because of one of those
3
3 things in your career?
I probably cancel 3 to 4 a month because people ate.
3 to 4 a month?
Yeah, I would guess across all the different procedures we do, probably 3 to 4 a month because patients show up and have eaten or are eating when they show up.
And are they charged for that partial time? Or
probably not.
Okay.
I wouldn't imagine they would be. Most of the time we catch it the second they walk into the pre-op area. See you later.
Are they surprised?
Sometimes. Yeah, I don't think patients understand.
Okay.
Why they, and that's part of what we're trying to do here is explain that to them. I don't think patients understand why they can't eat before surgery and that that's a true safety issue. Blood pressure is probably the second most common reason we cancel procedures. Patients who have super high blood pressures puts them at risk during surgery because, as we talked about, blood pressure goes down during surgery. So if your brain is used to 220 over 110 and I drop your blood pressure to 130, chance for a stroke. So that's probably the second most common reason that we cancel cases is elevated blood pressures. And then sometimes we'll have to cancel because patients either took or didn't take medications they were supposed to take or supposed to not take. But that's probably more rare.
Listen, take it from this guy. A double Big Mac can wait until after the surgery.
Yes,
it's much better after the surgery, too, on the way home.
Or just make sure you eat it like 12 hours before surgery. That's either way before or after.
It's a good snack afterwards.
Yeah,
it is. Consult with your physician.
Yeah.
Thank you, Dr. Brian Schmutzler. Again, this is very informative, and it's providing education for those folks who really don't know or want a better understanding. So we appreciate it.
Absolutely, my pleasure.
This is Going Under Anesthesia Answered with Dr. Brian Schmutzler. You can follow him on all social media platforms, YouTube, and of course on his website at www.drbrianschmutzler.com. We'll see you in the next one.